During your call, press *0.
After the tone, please state your name, followed by the pound sign.
I'm sorry, we did not get your name.
After the tone, please state your name, followed by the pound sign.
I'm sorry, we did not get your name.
After the tone, please state your name, followed by the pound sign. This conference is in silent mode. There are 21
parties in conference, including you.
About pregnancy and the hemoglobinopathies. Dr. Lanzkron is an associate professor of medicine and oncology in the Division of Hematology at the Johns Hopkins University School of Medicine. She received her undergraduate degree from Brandeis University and her medical degree from the Albert Einstein College of Medicine. She completed her internal medicine training at the University of Maryland Medical System and pursued her hematology clinical and research fellowships at Johns Hopkins. Dr. Lanzkron's clinical and research interests have centered on the delivery of high-quality care to individuals with sickle cell disease. In 2009, she received her master's in health science from the Bloomberg School of Public Health. In 2008, she opened the Sickle Cell Infusion Clinic, which provides urgent care to patients in crisis so that they can bypass the emergency department. Dr. Lanzkron has established the Sickle Cell Center for Adults at Johns Hopkins, which in 2001 served the needs of about 50 patients and has now grown to a multidisciplinary comprehensive clinic that cares for 500 adults with sickle cell disease. So I'd now like to turn the presentation over to Dr. Lanzkron. I'll ask you to please unmute your line by pressing *6, and you can go ahead and begin.
Thank you very much.
Thank you so much.
Welcome, everyone, this afternoon. I am going to talk about pregnancies and the hemoglobinopathies. Can I have my next slide, please? My disclosures, I have some funding through the NHLBI, and I'm going to briefly discuss the off-label use of deferoxamine. The objectives of this talk will be to understand the risks of pregnancy in thalassemia and sickle cell disease, understand how iron overload can affect pregnancies in thalassemia, and discuss management strategies for both sickle cell disease and beta thalassemia major. So there have been significant improvements in overall survival for women with both of these disorders, and these have led to prolonged survival and improved quality of life. And while that has improved, unfortunately, research regarding optimal management of hemoglobinopathies in pregnancies has really been lacking. Because there's a lack of data, the management of individuals or women who are pregnant with these hemoglobinopathies really requires specialty care from both the hematology side as well as from the obstetric side. To give you a little bit of background, sickle cell disease and beta thalassemia are autosomal recessive disorders of the beta globin gene resulting in severe anemia. For sickle cell disease, there are about 90,000 people, we think, in the U.S. who live with this disease and millions worldwide. The manifestations that are important in pregnancy and outside of pregnancy include painful crisis, acute chest syndrome, and then other things that need to be thought about during pregnancy are the effects of sickle cell disease on organs, including pulmonary hypertension, chronic kidney disease, and CNS disease. For beta thalassemia major, there are only about 1,000 people in the U.S. with that disorder, but it is highly prevalent in other parts of the world, including India and Southeast Asia. It is manifest by extramedullary hematopoiesis, and because women with this disorder require chronic transfusions for just about their entire life, the major complications that we see are due to iron overload, and individuals who are pregnant have the consequence of that iron overload, including endocrine disorders, heart failure, and cirrhosis. So the data for women with beta thalassemia major is really limited. I'm going to show you what's out there, and there are really just a few case series that is really going to represent the data that I'm going to show you today. And why is there such limited data? There are probably a couple of reasons for that. One is that most women who have this disease live in developing countries where there's a lack of research infrastructure. And then the second reason is because of the iron overload, many women have hypogonadotropic hypogonadism and are not fertile or need help becoming pregnant, and those resources aren't available where many of these women live. So there's just not a lot of data out there. As I mentioned, the major complications associated in pregnancy are really the complications associated with iron overload that happens because patients required hypertransfusion therapy, requiring transfusions every 2 to 4 weeks from very early on in their lives. When you think about the heart and pregnancy, this is where often the complications occur. So in pregnant physiology, there's an increase in cardiac work by 25 to 30%. There's an increase in blood volume, which peaks at 24 to 28 weeks, and there's a decrease in systemic vascular resistance. At delivery, uterine contraction rapidly shifts 1 to 2 units of blood from the uteroplacental circulation to the systemic circulation, and some think that this might be a significant cardiac stress for these women. In addition to the effects of iron overload on the heart, it affects endocrine organs. Infertility is seen in as many as 2/3 of women with beta thalassemia major. They also develop diabetes, hypothyroidism, osteoporosis, and because women get transfused and are exposed to transfusions over such a long period of time, viral exposures are also an issue, including hepatitis C, B, and HIV. So now I'm going to talk about these case series, the sort of wealth of data that's out there, and we're going to travel around the world to different countries that have looked at outcomes for women with beta thalassemia major. So the first stop is London, and in this study there were 29 pregnancies in 22 women. These were mostly in the 1990s. The maternal age range was 19 to 38 years. Ovulation induction was required in almost half of the women in order for them to become pregnant. In this group of women, there were significant comorbidities prior to pregnancy, including 5 who had cardiac dysfunction, 4 that had diabetes, and 9 with osteoporosis, and then a number with hepatitis. Looking at the outcomes for these women, there were 26 newborns from 24 pregnancies. There were some pregnancy terminations and spontaneous miscarriages. Deliveries preterm were only 4 out of 24 of the pregnancies. Most of the women required cesarean sections, and there were 2 maternal deaths, both of cardiac failure. Both women had known prior cardiac disease. 1 died 10 days after delivery, and 1 9 months after delivery. In a study of Greek women, this study was a little bit different in that this is a highly selected group of women who had well-controlled disease, so did not have significant iron overload. They only included women who had normal left ventricular function and a baseline rest echo with an EF of 55%. During the pregnancies, all women were maintained with a hemoglobin of 10 grams per deciliter, and a priori they decided they were going to deliver all the women by elective cesarean section. There were 21 healthy infants with a mean birth weight of 3,000 grams. The complications seen were minimal, but they did note some cardiovascular changes, including significant increases in left ventricular mass and right ventricular dilatation that developed during gestation and improved after delivery. Echo studies 5 years after delivery did show an increase in left ventricular cavity size and mass, and left ventricular contractility was reduced in 1 woman 9 years postpartum. And you may ask, why do I care what happened 9 years postpartum? I think they included it because there's so little data out there, but honestly, nobody really knows what the natural history of left ventricular contractility is for women pregnant or not, so it's unclear if that's really important, but it is something that they reported in that case series. Now moving to Italy, where there were 58 pregnancies in 46 women. The mean age was about 30 years. Again, many of the women required ovarian stimulation in order to get pregnant. This also was a relatively healthy group of women. Less than 5% had an EF of less than 45% pre-pregnancy. 38% had hepatitis C. They planned to keep the pre-transfusion hemoglobin kept at almost 9 grams per deciliter, and because of the increased need for red cells, blood consumption increased from 132 mils to 157 mils of red cells per kilogram per year. 91% of these pregnancies resulted in a live-born neonate. A third were premature. Again, almost all of them were delivered by C-section, and none of the babies became Hep C positive. Again, they noted transient increases in left ventricular and diastolic dimension and heart rate, but these returned to baseline following delivery. So based on these case series, these are the current recommendations for women with beta thalassemia major who are pregnant. First is that cardiac function should be assessed, ideally before pregnancy. So doing an MRI or T2 star of the heart to evaluate how much iron is in the heart and if there is a significant impact on cardiac function. Doing an echo to evaluate for ejection fraction is also important. And if women aren't screened prior to pregnancy, then the recommendation is to do an echo early on during pregnancy. Also recommended is screening at the first prenatal visit for impaired glucose tolerance and hypothyroidism for women who may suffer from this but have not yet been diagnosed. Ensuring calcium and vitamin D intake, treating hepatitis C prior to pregnancy, and appropriate prophylaxis to those to prevent HIV transmission. Most of these women, not all of these women, are on chelation therapy prior to pregnancy in order to keep their iron levels down. That should be discontinued at the time of pregnancy. Deferoxamine has possible teratogenic effects observed in animal studies. Deferoprone is the newest oral iron chelator that's been approved in this country, and its risk to the fetus is unknown. And deferothyrox, there has been noted minimal placental transfer in animal models, but there haven't been any human studies done. So it's really thought unknown whether these chelation agents are safe during pregnancy. There is mention that in women who you're very concerned about their cardiac function during pregnancy and their risks of worsening of their iron overload, that potentially desferol could be restarted after the first trimester, but obviously the benefits would have to significantly outweigh the risks. Women should continue with their hypertransfusion therapy during pregnancy. Again, sort of based on the data that I've shown you, which is not robust, the recommendation is to keep the pre-transfusion hemoglobin at 10 grams per deciliter. And then the question of how to deliver these women, the rate of C-section approaches 80%. I presented this to a group of obstetricians, and they didn't believe that delivering by C-section was better than a normal vaginal delivery when it comes to cardiovascular stress, so I would discuss that with the obstetrician. But really, the most common reason that women need a C-section is because of cephalopelvic disproportion. Women who have thalassemia tend to be small, but yet their babies have normal fetal growth, and because of that, they often require a C-section in order to deliver. I'm now going to move on to sickle cell disease. So for sickle cell disease, there's an increased plasma volume relative to erythrocyte production that can worsen anemia. Maternal oxygen reserves are often compromised due to increased oxygen consumption and a decreased functional residual capacity during gestation. And the risk then for women with sickle cell disease in pregnancy is due to worsening anemia, impaired oxygen delivery, and sickling. Unlike thalassemia, there are a number of different studies that have been done. They're not adequate to make complete recommendations, but at least they're more than what has been done in thalassemia. There are a number of retrospective studies, a couple of cohort studies, and, in fact, one randomized controlled trial that we'll talk about. So the largest cohort study is the cooperative study of sickle cell disease. This was a cohort that was recruited from 19 centers for a prospective study of the clinical course of sickle cell disease. There were over 3,000 participants. Amongst those participants, there were 445 pregnancies that were recorded from 1979 to 1986, and it's just important to note that the study was done quite a long time ago. There were 2 maternal deaths, both in women with SS disease. In looking at complications during pregnancy in this cohort of women, 50% of the women with SS disease had at least one painful episode during their pregnancy, and this was more than individuals with SC disease, but you can see quite a large number of women with S beta plus thal had painful episodes during their pregnancies as well. The percent of women who had acute chest syndrome during their pregnancy was only 7% for women with SS disease. Importantly, when they looked at baby outcomes, the most significant thing that came out was birth weight. So in looking at the individuals with SS disease, almost 40% of the women had babies that were less than 2,500 grams, so significant intrauterine growth retardation. So what they concluded from this study is that the course in women with SS disease was not adversely affected by pregnancy, and they looked at how many vaso-occlusive crises these women had prior to pregnancy and during pregnancy and noted that they were the same before, during, and after. There was no increase in pyelonephritis or placenta previa, but this was sort of the first large study that showed that infants were at increased risk for low birth weight. In 2004, Graham Sargent published his cohort of women with sickle cell disease, and he compared that to a cohort of controls. They had 54 pregnancies in 35 subjects. 20% of the women had vaso-occlusive crisis during their pregnancies, 20% had acute chest syndrome, and 15% had a urinary tract infection during their pregnancies. People with SS disease had a later first pregnancy and more spontaneous abortions. Babies of moms with SS disease had low gestational age, so 44% were born preterm. Low birth weight, again, large percentage, less than 2,500 grams. And in a regression model, they demonstrated that low birth weight was significantly associated with having had a UTI or vaso-occlusive crisis during pregnancy. There was no difference in pregnancy-induced hypertension, preeclampsia, or hemorrhage. 2 of the women with SS disease died with a mortality rate of 2.1%, but there were no deaths in the control group. And they concluded that pregnancy was associated with significant maternal morbidity and intrauterine growth retardation. In 2011, the same group looked at all maternal morbidity in Jamaica, and they found that women with women with sickle cell disease accounted for 9.3% of all maternal deaths from the period of 1998 to 2007. 80% of these women had SS disease, and maternal deaths in women with sickle cell disease compared to women without sickle cell disease, those with sickle cell disease were more likely to have been enrolled in a high-risk antenatal clinic and had more antenatal visits. This study is a large study looking at lots of pregnancies. This data was taken from the National Inpatient Sample, which is a data set that contains a representative sample of all hospital discharges in the United States. And this group looked at all of the pregnancies between 2000 and 2003 and compared it to controls. So found about 18,000 deliveries of women with sickle cell disease and compared it to controls. And what they found was that thrombotic complications were significantly higher in the group with sickle cell disease. In addition, women with sickle cell disease were more likely to have pneumonia during their pregnancy, and more likely to have a urinary tract infection during their pregnancy. Next slide. When they looked at fetal complications, again, they saw an increased risk of intrauterine growth retardation, as well as preterm labor. There was also an increased risk of eclampsia. When they looked at the overall mortality rate for women with sickle cell disease, they found it to be 72.4 deaths per 100,000 deliveries, compared to the controls, which was only 12.7 per 100,000 deliveries. In 2 more recent publications, looking at countries outside of the U.S., the first one is from Saudi Arabia, where they looked at 10 years of data and identified 392 pregnancies in women with sickle cell disease. In this group, there were 2 maternal deaths, but the perinatal mortality rate was 77.7 per 1,000 deliveries versus 18 per 1,000 deliveries for women without, for babies born of women without sickle cell disease. And then looking at the data for Ghana, there were 253 pregnancies over a 2-year period of time, and the mortality rate for the moms was 83 deaths per 1,000 deliveries, compared with a mortality rate of 6.9 deaths per 1,000 deliveries for women who did not have sickle cell disease. And so women with sickle cell disease represented 7.2% of all maternal deaths. And there was also noted an increased risk for intrauterine fetal death in that cohort as well. And this Medicaid paper is the most recent publication looking at pregnancies. This is back in the United States. A group looked at Medicaid healthcare claims from 2004 to 2010. And they looked at all African American women from the ages of 15 to 44, and they broke the women into three groups: those with sickle cell disease, African Americans with chronic conditions, and those chronic conditions are listed there, and African Americans who had no chronic conditions. When looking at the results, you can click again. You can see the first set of columns are women with sickle cell disease. The second set are women without sickle cell disease but with one of those other chronic conditions. And the third column was not having sickle cell disease and not having a chronic condition. When you look at the different complications, postpartum infection was seen more in women with sickle cell disease than either of the other two groups. Pneumonia also seen more commonly in women with sickle cell disease, as was sepsis and urinary tract infections. The obstetric complications, women with sickle cell disease were more likely to have obstetric shock, and eclampsia was seen more often in women with sickle cell disease when compared to the controls without a chronic illness. And again, we see this increased risk of DVT in women with sickle cell disease, more so than in African American women with a chronic condition and African American women without a chronic condition. And then finally, not surprisingly, women with sickle cell disease were more likely to be transfused and were more likely to have a C-section when compared to women without a chronic condition. So what about management of this group of women? This is where we have the one randomized controlled trial, which was a prospective study that enrolled 72 pregnant patients with hemoglobin SS disease who were randomly assigned prior to 28 weeks of gestation to either monthly prophylactic transfusions or red cell transfusions only for emergencies. There were no differences between the two groups in analgesic use or smoking history between the two randomized arms. They noted no significant difference in perinatal outcomes. The rate of intrauterine growth retardation was 14% in the transfusion arm and 18% in the controls. There were 11 perinatal deaths. Prophylactic transfusion did significantly reduce the incidence of painful crises and significantly reduce the cumulative incidence of other sickle cell disease complications. But there was no improvement in the survival of mother or fetus with prophylactic transfusion. They had twins, a mom with twins in both arms of the study, and none of those twins survived, so they did not think the prophylactic transfusion decreased the risk and did think that twins might be an increased risk for women with sickle cell disease. Because they were their concerns were towards costs and the risk of hospitalization and the risk of immunization, they did not feel that there was an overall benefit to providing chronic prophylactic red cell transfusions for moms with sickle cell disease. We might look back at this and say that, we no longer have to hospitalize women for chronic transfusion therapy, and the risk of immunization is much lower now because we're much better at getting genotypes and giving phenotypically matched red cells, that maybe those concerns wouldn't weigh so heavily at this point, and we'll talk a little bit more about transfusion in a minute. What about hydroxyurea in pregnancy? The Center for Evaluation of Risk to Human Reproduction performed a literature review in 2007 looking at all of the toxicity associated with the use of hydroxyurea. And when they examined developmental toxicity in humans, they didn't find that there was sufficient data to make any conclusions about the effects of hydroxyurea exposure in utero. And then they looked at data of developmental toxicity in animals, and they felt that there was sufficient data to conclude that there was developmental toxicity in rat and mice fetuses exposed in utero to hydroxyurea. And because of that, they had concerns that hydroxyurea may increase the risk of congenital anomalies or abnormalities of fetal growth after exposure in pregnant women, so did not recommend the use of hydroxyurea during pregnancy. What about opioids in pregnancy? So there's very little data on opioids for chronic pain. There's a little bit of data about the use of opioids when they're given for women with addiction. Most of the data we have is survey data where they ask women to remember what they took after the pregnancy, which has its own set of limitations. But what they did find from some of the survey data that opioids seem to be associated with low birth weight, premature birth, and neonatal death. But it's very difficult to separate out the effects of opioid use from other maternal factors that contribute to poor outcomes. We have recently looked at our Hopkins data and looked at all pregnancies in women with sickle cell disease between 2001 and 2011, and we abstracted the data listed below. And the mean maternal age of the women was 26 years. 57% of the women had SS disease, and the mean daily opioid dose, or morphine equivalent is how we measured them, for those on chronic opioids was 282.5 milligrams a day. The mean gestational age was 37.4 weeks, and neonatal abstinence syndrome, so the babies born with withdrawal symptoms, occurred in 21% of live births. When we looked at this using a logistic regression model, we found that the dose of morphine, so for every 10 milligram increase dose of morphine equivalent that women were taking daily, it increased the risk that their baby would be born with neonatal abstinence syndrome by 10%. And also, interestingly, gestational age. So for every 1 week increase that the baby stayed in mom, there was a significant reduction in the risk of neonatal abstinence syndrome, suggesting the possibility that maybe potentially a more mature liver is able to handle these opioids better and decreases baby's risk of developing withdrawal symptoms after delivery. So the current management recommendations are to stop hydroxyurea until the mom is no longer breastfeeding. There's one case report that shows that hydroxyurea can be expressed in breast milk. Screening women for hepatitis B, C, and HIV is important, as many of them have been transfused prior to pregnancy. We screen for red cell immunization, screening for proteinuria and preeclampsia, and then appropriate and rapid management of painful episodes. It is important to emphasize that we need to treat women for pain during their pregnancy as much the way we would treat them when they're not pregnant. And so we do recommend the use of opioids, but discussing the risks and benefits with moms is important. Unfortunately, there's very little data to have that conversation with the moms, but hopefully that will improve in the coming years. And then the other thing, based on our very preliminary data, is that potentially we may be able to decrease the risk of withdrawal symptoms in the baby if baby stays in mom longer and goes till term. There is, as I mentioned, limited data on the use of transfusions. The one randomized study didn't randomize women until 28 weeks in pregnancy, and maybe you couldn't impact on intrauterine growth retardation when you start transfusions so late into a pregnancy, and it's just very limited data that's available for us. Our current practice is to routinely put women who were on hydroxyurea prior to pregnancy on chronic transfusions throughout their pregnancy, and then we routinely put women who seem to have more crises early on in their pregnancy on chronic transfusion therapy. Because complication rates are high, women need to be followed by high-risk OB. I send all of my patients to high-risk OB and have active hematology involvement in their pregnancies. So in conclusion, pregnancies and hemoglobinopathies is associated with significant morbidity and mortality. We don't really have enough randomized studies or even cohort studies to support true evidence-based guidelines. It's also really important to note that there are poor outcomes for moms and babies with sickle cell disease, many of whom are born in resource-poor countries. So suggesting potential expensive therapies like exchange transfusions throughout pregnancies are really going to be impractical and not helpful in those parts of the world, and so we need to think about therapies that might improve outcomes in resource-poor countries. And overall, we just need more data to assist with counseling women about the risks of opioids during pregnancy. Thank you.
Thank you so much, Dr. Lanzkron. This was really, really wonderful. So we now have the lines open for questions, if anybody has a question. So just to remember, if you do have a question, to raise your hand electronically by clicking on the Q&A tab, or if that's not available for you, if you'd like to press *6 in order to unmute your phone and ask Dr. Lanzkron a question. So it doesn't look like we have any questions electronically right now, so I'm more than happy to open the phone lines up. If anybody has one, just press *6.
Hello?
Yes? Yes.
Hi, this is Nancy Green from Columbia. That was a wonderful presentation. Thank you very much. Very enlightening. So if you were going to design a randomized trial for pregnancy management in sickle cell, what would you do?
Well, so I would go back to the transfusion issue. There is one small study that looked at women who are on a cytopheresis on exchange transfusions for they've been on it before they got pregnant. And it's really the only study I've seen where they have been able to decrease the risk of intrauterine growth retardation. So although this is not helpful for resource-poor countries, I think that that's the randomized study that I would ideally want to do. I think there are also risks associated. We see a lot of preeclampsia here and eclampsia here. And so the question of whether the use of aspirin would decrease that risk, I think, is also a question that we should ask.
Great. Thank you so much. Great question also. Any other questions on the phone? Oh, we have one online. Let's see. This is from Brittany, and she's asking, why do women with sickle cell trait have increased risk for UTI?
That's a good question. I'm not sure I can really answer that question. We know that the renal defects, kidney defects that we see in women with sickle cell disease are seen also in women with trait, but not to quite the extent. And so I don't really know the answer to that question, but I presume it is from the effect of renal damage from sickling in the kidney, but I do not know.
Thank you for that. So no more questions on the computer, but anybody else who would like to ask us through the phone, if you just want to press *6 and ask your question, please do so now. Any final questions? Okay, great. Well, thank you so much, Dr. Lanzkron. This was really fabulous. I know I learned a lot today, so hopefully everybody else did too, and we had lots of people participating. So, one more just came in. We have a question from Brenda asking if there's any data on women with sickle C disease.
So I've sort of presented what's out there. If you look at the slides from the cooperative study, they do look at outcomes for women with SC disease. It's very limited because there just weren't that many women in that cohort who had pregnancies. They have the same sort of complications. They seem to be at less risk of their babies having intrauterine growth retardation, but it does happen. There's just very little data out there.
Great.
Can you hear me, Mary? I have a question.
Yes, I can, yes.
Okay, hi. Thank you so much for the wonderful review of the literature. So one of the things you talked about was pain management, which obviously can be very difficult because a lot of the patients have to take narcotics, especially for sickle cell. So my question is, in your practice of taking care of women and just men in general, what pain management regimens have you found that are useful that could be applied for pregnant women that may not have the same side effects?
Well, so we use the same practice we do when women are pregnant or not pregnant in managing their pain, and we go up that WHO, ladder. We can't use non-steroidals during pregnancy, and so don't. But we use long-acting and short-acting opioids to manage pain. And we're sort of stuck with this, right? It's not very good when you're not pregnant. Those drugs are not great in managing pain, but we're very limited in what's available to use, and so that's what we use, and we use it as needed to help control pain and keep women out of the hospital.
Wonderful. Any final questions? Okay, one more on the computer. This is from Dina, I believe. If a child is born dependent, what is the treatment? I'm not sure.
Yeah, I'm an expert on that subject. So I'm not an expert on that subject. What we've learned is they end up having prolonged hospital stays and often end up in the intensive care unit for treatment and management of their withdrawal symptoms. Some of those babies actually end up having to be transferred to sort of a long-term stay for weeks and weeks of essentially a detox therapy off of those. I don't really know the details because I don't take care of the babies.
Okay, another question from Brittany Kinder, maybe. If mom has trait and father has trait, is there any way to find out, before birth, if the baby has the disease?
There are multiple ways to tell. So you can start even before pregnancy using pre-implant genetic diagnosis, which can be used to select out embryos that don't have sickle cell disease. And then the earliest on testing you can do during pregnancy is chorionic villus sampling, where you take blood from the baby, and you can use that to test to see if the baby has sickle cell disease. And finally, amniocentesis can be used as well to see if the baby has sickle cell disease.
Thank you so much. Give another second, because it seems like the questions are trickling in. Let's see if there's any more. Anybody on the phone? Okay, so I think that's it for today. You've covered a great range of we might have one more question. Sorry. Okay, I think this is another one from Brittany. I'm not sure if this is something for this talk, but I'll go ahead and ask it. Does Medicaid cover the cost of amnio if mom and dad have trait? That might be on a case-by-case basis. I'm not sure.
And I don't know.
I don't either.
Yeah, sorry.
Okay, so we're going to wrap up for today, and thank you so much. This has been really, really wonderful. So the next webinar that we have, you can see on your screen. It will take place on Thursday, June 27th. The title is Beta Globin Haplotype Analysis in Children with Sickle Cell Anemia, and that will be presented by Dr. Christopher Bean. So it's a little bit of a departure from some of our usual webinar talks, but I think you guys will really enjoy this. It's a little more science-y than what we usually hear, but certainly I've seen some of this data, and it's pretty exciting, so hopefully you will join us for that. And if anybody has any questions, I would like you to please feel free to contact Shay Pope. Her email address is on your computer screen. It's spope@cdc.gov. And as a reminder, the recorded webinars are available at scinfo.org if you click under the webinars toolbar. So thank you so much, Dr. Lanzkron. Thank you, everybody who participated and who attended the webinar today. And we will talk to you in 1 month. Thank you so much. Bye-bye.